morning to everyone, and we are very happy to be with you today. This session is called Lung and COVID, and we have three great speakers that we will introduce you. I have the pleasure to co-chair this session with Professor Cristina Ersu. She comes from the Craiova University, and she is the representative of the infection section of the ERS. The three speakers that we have are very important people, and I think the presentations are going to have a big impact. So I'm going to introduce first speaker, and then I will introduce the second and the third. The first speaker is Professor Refika Ersu. She works in the paediatric respiratory medicine in the Children's Hospital of Eastern Ontario in Canada. And her talk is called, as you see in the screen, COVID-19 Impact in Children with Chronic Respiratory Condition. Refika, it's your turn. Welcome, and it's your turn. Good morning.
Good morning, everyone. It's such a big pleasure to be here. I also represent the ERS Pediatric Assembly, and I'd like to thank both the organizers and the ERS for the opportunity. I don't have any conflict of interest. I'll briefly review the COVID-19 infection in children. This will not be an exhaustive review, because what I want to emphasize is more infection and risk in children with chronic lung disease. Children are resilient and have represented less than 4% of cases of COVID-19 infections and have been greatly spared, fortunately, from many of the acute complications. However, they've had to endure many changes in routine, social interactions, education, and access to basic health care. I think it's important to emphasize the health inequalities here, because the children are sometimes more affected than adults, especially in low and middle income countries. So there are indirect effects of the pandemic on the health of children, which are increasing poverty levels, disrupted schooling, reduced access to healthcare facilities, and interruptions in vaccines. And especially if the health systems are under-resourced, there may be a diversion to resources to support the adult services, which may further compromise child health. There are some differences in the manifestations of children that are different than adults. And the main one is that in children with COVID-19 infection, they may actually just present with mild viral upper airway infection symptoms, such as pharyngeal erythema, rhinorrhea, and nasal congestion, which are different than adults, but they may still have presentation with dry cough and tachypnea similar to adults. The first sizable assessment in China from children was quite encouraging. Only 40% of infected children in China developed fever, while 20% only manifested symptoms of upper respiratory infections. Children usually got infected from contact with an infected household member, and 1/5 infected children were asymptomatic. 1/10 infected children had radiological signs of pneumonia, but they remained asymptomatic as well. Younger children were more likely to be symptomatic when compared to older children and adolescents from the initial reports in China. As I mentioned previously, I will not go to exhaustive review of COVID-19 in children, but I want to mention this study, which has been the biggest study from Europe so far and was reported in Lancet. 82 participating healthcare institutions across 25 European countries. This study was conducted through the Pediatric Tuberculosis Network European Trials Group. They looked at the COVID-19 infection in children aged 18 years or younger during the peak pandemic season in Europe between April 1st and April 24th. There were 582 children with a median age of 5 years. 25% had pre-existing medical conditions. 62% of those children who were infected were admitted to the hospital, and 8% required ICU admission. Although this seemed high, authors commented that this was mainly conducted from these centers, which were tertiary care centers. 4% required mechanical ventilation, and there was one child who was on ECMO support. The risk factors for ICU admission was being younger than 1 month of age, male sex, pre-existing medical conditions, which included chronic respiratory problems. And if there was a presence of lower respiratory tract infection, signs or symptoms as presentation, then children were more likely to be admitted to the ICU. The most frequently used drug was hydroxychloroquine in this study, followed by antivirals, immunomodulatory medication, including corticosteroids. 4 children died. So case fatality rate was 0.69. And all the children who have passed away were older than 10 years of age. Although 2 of them were previously healthy, one of them had a human stem cell transplant 15 months prior to the COVID-19 infection, and one patient was in palliative care because of a serious underlying condition. So how about COVID-19 in children and chronic respiratory conditions? While COVID-19 is a multi-system disease, it predominantly affects lungs. And thus, it's critically important to understand whether chronic lung disease places children at higher risks. As a respirologist in pediatrics, we always get questions by parents about COVID-19 and safety of attendance to daycare, schooling, and in children, especially in children with comorbidities such as asthma or cystic fibrosis. Well, for children with chronic respiratory conditions, parental and healthcare professionals' concern is heightened, and it is reasonable to consider that these children may be at higher risk for severe disease. And statements for protection strategies are based on the experience from adult patients, where comorbidities are relevant risk factors. So we really need the urgent data to see if we really need to shield those children. So there are many studies looking at COVID-19 and including the COVID-19 in children. However, there are only few reports on children with chronic respiratory conditions and even less reports on specific outcomes. The study I just mentioned with 582 children over Europe, they mentioned there were 26 children with chronic respiratory conditions, 12 with asthma, and 6 with bronchopulmonary dysplasia. 6 of those were admitted to the pediatric intensive care unit, but there were no further details. So for the rest of my talk, I will concentrate on the study that was recently conducted by the European Respiratory Society Pediatric Group, and these slides are the courtesy of Dr. Muller, who conducted the survey. So this was sent to 170. This was sent to the centers in Europe, and 174 centers replied. 94 centers entered data from a total of 945 children with COVID-19 infection, which is quite a big database. So when we look at the age distribution, there are 125 from 0 to 1 years of age, around 131 to 6 years of age, and majority of children are older than 6 years of age. There were 49 children with asthma and COVID-19 infection. So they did present mostly with upper respiratory tract infection, but there were some patients with exacerbations and findings of pneumonia. Although most patients were admitted, 1/3 were sent home. And when we look at the admission and respiratory therapies they required, most of them did not require much treatment, and only a couple required invasive ventilation. There were no deaths reported in this asthma group, and most of the patients were treated with antibiotics. How about the other data from around the world? In Bronx, New York, 11 asthmatics out of 46 children admitted to hospital was found, but this was not associated with admissions to pediatric intensive care unit. In Lombardy in Italy, which was one of the epicenters in Europe, 1 asthmatic out of 40 children with COVID infection was reported. In China, similarly, 1 out of 34 children. And in Brazil, 3 asthmatic out of 79 children admitted to ICU. And again, in New York, there were 24% of children with asthma who were admitted, but asthma was not associated with adverse outcomes. So this data is quite reassuring for children with asthma, and especially when we look at this research letter from Slovenia, asthma admissions actually decreased when they compared it to the previous years, despite the presence of allergens in the allergy season. And also, which was really nice and surprising, was that the air pollution also decreased. So this is a secondary effect to lockdown. In adults, there are similar reports that maybe asthma and COPD are underrepresented in the comorbidities reported for patients with COVID-19. So if asthma is indeed protective, it could be secondary to a couple of things: changes in the immune response, maybe the inhaled corticosteroids, suppressing the coronavirus replication, or reducing the ACE2 inhibitors, ACE2 receptors. So how about cystic fibrosis? There were 13 patients in the cohort from European Respiratory Society with cystic fibrosis. And those patients were admitted. So most of them were either in the intensive care unit or the ward, but they again were represented with the upper respiratory tract infection, but some also with pneumonia and exacerbations. Although despite this high admission rate, most of the children did not require much respiratory support. 1 patient with invasive ventilation, 2 patients with oxygen, and mostly treated with antibiotics, and again, no death. So this was from the European Respiratory Society. How about the European Cystic Fibrosis Society? There were 145 cases with COVID-19 infection from the European Cystic Fibrosis Society patient registry, unpublished data, again, the courtesy of the Dr. Muller. And there were the hospitalization rate was quite high with 46%, again with a 5.5% with ICU admission. There was mortality in this patient group, but I want to take your attention to the age groups, because only around 30 of those patients were in the pediatric age group. So this did include adults with cystic fibrosis and COVID-19 infection, which may look like a risk factor for more severe infection. We're also interested in children with bronchopulmonary dysplasia. And in this group, there were 9 with bronchopulmonary dysplasia and COVID-19 infection. They again required either ward or pediatric intensive care hospitalization. And although there were signs of upper respiratory tract infection, there were kids with pneumonia and exacerbation also. And when you look at the treatment support with respiratory support, then these patients required more oxygen than patients with asthma or cystic fibrosis. But again, there were no deaths that were reported. So these patients from the European Respiratory Society cohort had similar findings to the other cohorts in children with when we compare with the radiology findings. They had ground glass opacities on their CT and also some local or bilateral patchy shadowing. So in conclusion, the low numbers of children with asthma admitted to hospital and ICU suggest that these children may not be at risk for severe COVID-19 infection. I need to emphasize here that this is true for children with good asthma control, and it may not be true children with more severe asthma who may require biologicals or routine systemic steroids. Still, a sizable minority of children with bronchopulmonary dysplasia and respiratory diseases other than asthma might be at risk and may benefit from being shielded. So there are only few numbers on children who have tracheostomy, home ventilation, or neuromuscular disease. So when we look at them individually and gather our data together, we may see that indeed these kids may be at risk. So I think there still needs to be caution for those kids. These emerging findings may be useful for governments planning for provision of care over the coming months and years, and we need to still continue to gather that data. There are real concerns about the spread of misinformation on social media about exaggerated risks of developing COVID-19 by visiting physicians' offices or the risk of immunization. So there are reports for children who have passed because they were too late for coming to medical attention because of the concerns of COVID-19 infection. So this remains to be a risk for children. So we need to really balance that out. So when to get a good, when to access healthcare and when to stay at home, those are the things that we still need to work more. So I would like to acknowledge Dr. Alexander Muller for sharing his European data, which is in press in European Respiratory Journal, Open Access Journal. And thank you for your attention.
Thank you very much for your great talk. Very interesting. There is no questions from the public. I would like to ask you only one question. I don't know if Christina wants to do another one. I know that numbers are very low, and these kind of people with severe disease are minority. But what do you think is going to be the evolution of these kids with severe disease? Are they going to have a good prognosis or not so good?
I think we're going to see increased numbers, and then maybe it will become more apparent as the schools are opening or already opened. There are, in my personal practice, I have seen some kids who have had probably COVID infection, not proven, but around the same time, COVID was more prevalent in the community. They have had prolonged cough. But no changes on the chest X-ray. So there are now studies that are going on looking at the long-term lung function. It's hard to justify from ethical point to obtain CTs in these patients. So far, I think the chest X-rays have not revealed a lot of things in the long term, but I think we'll wait and see if the lung functions of at least some of those children, especially if they have an underlying disease such as BPD, would show us any chronic problems. Thank you for your question.
Thank you very much. Christina, do you want to ask anything?
No, just to say congrats for her presentation. Very interesting, very good.
Thank you.
Okay.
Could I ask something, or we don't have time?
Very short.
Very short question. It seemed that in adults with severe asthma, at least there is a SANI publication from SANI group. It seems that the biologic treatment, so well-controlled asthma, was not a risk for these patients. Do you think that biologics could also protect, let's say, the patients through different pathways? Or it seems that the lockdown and the control of asthma is enough? Just a short answer.
So yeah, very short answer. I don't know. I think we'll have to wait and see, but it's very pleasantly surprising that less admissions for children with asthma.
Great presentation. Congratulations.
Thank you too. Okay, just one very short thing. I didn't introduce myself at the beginning. I'm Joaquín López Contreras. I belong to the University Sant Pau Hospital in Barcelona, and I'm here probably because I'm a scientific officer of the nosocomial group of the ECCMID. Now is the turn of Professor Jan van Meerbeeck. He works in the Antwerp University Hospital in Belgium, and he is here on behalf of the TerraVault initiative that we have read in the papers, and I think this talk is going to be also a very good one. Jan, it is your turn.
So good morning, and thank you to the organizing committee for inviting me to present here, also on behalf of the TerraVault collaborators, the interim results of our survey conducted in lung cancer, thoracic cancer patients. So I'm a thoracic oncologist in Antwerp, Belgium, but I'm also the assembly head of Assembly 11 of the European Respiratory Society. So what is the background? So what is the background of this presentation is that I have a noise in the background. So patients with lung cancer are at increased risk of complications and death due to the SARS-CoV infection. The reported all-cause mortality for patients with cancer and COVID-19 in large series ranges between 13 and 28%, which is much higher than in the community where figures of 1.8 to 7.2% are reported. Patients with hematological and thoracic malignancies seem to have even higher mortality, and the prognostic factors are well known to most of you. So in adults, it's age, performance status, comorbidities, stage status, gender, smoking, etc. So in view of the treatment those patients receive, chemotherapy and or immunotherapy, there is a debatable role whether these treatments have an interaction with the viral immune response and with the outcome of the infection. So this was the reason why multi-center international observational cross-sectional retrospective study was set up by a number of collaborators. It started in Italy with medical oncologists during the epidemic in Lombardy. And we included any patients with a thoracic cancer, be it lung cancer, mesothelioma, thymic tumors, or other neuroendocrine neoplasms, and a COVID-19 diagnosis. So there was a REDCap database built and put online where collaborators could enter data on demographics, history, comorbidities, the diagnosis of COVID-19, the cause of the illness, and the clinical outcomes. And this initiative was called TerraVault, being the abbreviation of Thoracic Cancers International COVID-19 Collaboration. So the aim of this survey was to determine which factors, which characteristics, and which therapies place patients at enhanced risk for infection, hospitalization, and death, to understand the cause in patients with thoracic malignancies, to provide some real-time data on therapeutic strategies so that clinicians or practitioners could adapt their treatment on the further insights, and to evaluate the long-term impact of cancer outcome related to possible care adjustments in patients with thoracic malignancies. So the initiative started in March in Italy and quite quickly spread out over 22 countries about worldwide, so in all continents. And the data I will present are the data based on a cutoff that was done in August, whereby 1,053 patients were included. But these data have been presented at various meetings. Interim results have been presented at the ASCR, the ASCO, the ISLC, and the ESMO meeting even last weekend. And there's even been a publication in the Lancet, I think it was in July. So what were the inclusion criteria? So any patient with a thoracic cancer, be lung cancer, mesothelioma, thymic tumors, or neuroendocrine tumors could be entered, provided they had a COVID-19 diagnosis, either laboratory confirmed or highly suspected based on clinical symptoms like fever, low saturation, diarrhea, otitis, dysgeusia, myalgia, arthralgia, conjunctivitis, and rhinorrhea, and a known exposure to a person with confirmed COVID-19, and radiologic suspected cases with lung imaging features that you all know from the recent publications. We looked at associations between the demographic and the clinical characteristics and outcome using odds ratio, using univariate and multivariate logistic regression. And as I mentioned, the cutoff of this presentation is August 20. So let me go to the first of results. So the median age in those 1,053 patients was 60 years, 58% was male. It was a primarily European population, and 82% had non-small cell lung cancer, of whom 58% had stage 4. The majority of patients were on active systemic cancer therapy, and the common presenting symptoms are not surprisingly fever, dyspnea, and cough. About half of the patients had overweight or even obesity. The majority of patients had at least one comorbidity, which is quite conform the population with lung cancer. So they have most hypertension, COPD, cardiovascular disease, and diabetes. 25% had even more than 3 comorbidities. 72% required hospitalization, 16% were admitted to ICU, and 8% were ventilated at the ICU. The most common COVID-19 related complication was obviously pneumonia and or pneumonitis. And 73% of the patients continued their treatment after the COVID-19 infection. So this is the slide on the outcome. It's quite a busy slide. You see different columns. The second column is in the whole population. The third one in third, fourth, fifth, and sixth in different subpopulations of patients with either small cell lung cancer, mesothelioma, thymic epithelial tumor, and neuroendocrine tumors. So the third line shows you the all-cause mortality according to the tumor type, and you can see that this is quite increased. So it's about 36% in the whole population, and in certain subgroups it even goes up to 45 and 41%, other ones are somewhat lower. So definitely there is an increased all-cause mortality, and the mortality is mostly due to COVID-19, as mentioned on the death certificate. In the total population, about 79%, and in some of the subgroups between 36 and 22%. So I mentioned already the hospitalization rate and the ICU admission, and the median length of hospitalization is about 10 days, with patients with small cell being about 2 weeks in the hospital versus the ones with neuroendocrine tumors, 6 days median. This is the multivariate analysis of prognostic factors, and you see in red those that are significant, so that are different, so that, whose confidence interval are either above or lower than the 1 unit. And as you can see, the highest risk factor is the performance status. Patients with a performance status of 2 or more, so with moderate or poor performance, have odds ratio of dying of 3.7, and which is significantly increased. The second highest risk factors is smoking status, which has an odds ratio of 2, followed by the stage of the cancer. So patients with advanced cancer have a higher likelihood of dying. Then there is the use of steroids prior to the COVID-19 diagnosis, odds ratio of 1.8. Then age, 1.53. What does not play a role, apparently, is the presence of comorbid hypertension and previous chemotherapy or treatment with tyrosine kinase inhibitors, so-called targeted therapy for driver-mutated lung cancer. So those odds ratio are not significant. So from this analysis, it appears that the administration of immunotherapy might perhaps be protective with an odds ratio of 0.06 and confidence interval between 0.05 and 0.097. So this is an interesting observation that maybe immunotherapy does not has a negative or detrimental effect on the outcome of cancer patients treated and infected with COVID-19. So this brings me to my conclusion. So patients with COVID-19 and thoracic tumors are at a higher risk of death compared to the general population, but also compared to other cancer types. And particularly small cell and mesothelioma patients have the highest mortality. The baseline risk factors for mortality include age, performance status, and the presence of certain comorbidities. Patients on steroids or anticoagulation prior to diagnosis are not at increased risk of mortality. I did not show you the data on anticoagulation, so they are there's no interaction. And prior administration associated with an increased risk of death, while immunotherapy is associated with a less extent risk of disease. Yeah. So for those of you who are interested, we have a website and the collection of data is still open. So you just can ask to be admitted as an investigator, and you can include your patients. So all this effort was set up in a couple of weeks, and the steering committee is on the slide and consists of people from different organizations. You have people from the European Society of Medical Oncology, the International Association of the Study of Lung Cancer, European Thoracic Oncology program platform, and the European Respiratory Society. So we are indebted and grateful to all those people for the effort and looking forward to your questions. Thank you very much.
Do you want to begin, Christina? There is no questions from the public. I don't know if Christina wants to ask you something.
No, just to say congrats for this huge effort that you have done. It was a very short time, and you managed to gather a lot of information. And the fact that immunotherapy is protective might be useful for treatment, maybe from now on. Just keep on the good work. Congrats for you and for the whole team. Maybe the other speakers want to ask Professor something?
I want to ask something. First, congrats for the initiative and for the presentation. Both things are great and impressive. I want to ask you, if we have a population that have a higher risk, what do you think about the screening asymptomatic patients before initiating chemotherapy in this population?
We have issued also with the European Respiratory Society a couple of guidelines, so how to go forward with this. Certainly now with the second and the third wave coming up. So in those patients in whom chemotherapy can be delayed or postponed, this should be preferred. And certainly the number of hospital admissions, so the visits to the hospital, to the outpatient clinic, should be restricted, either by, for instance, using oral therapy, or in some countries, the administration at home can be given by dedicated nurses. Regarding immunotherapy, you can give the double dose and spread and so increase the interval instead of every 2 or 3 weeks, now every 4 to 6 weeks, so that the risk of coming to the outpatient clinic is diminished. Regarding the treatment with chemotherapy in those patients who have a curative treatment option, like for instance postoperative chemo or induction chemotherapy in patients with stage 3 lung cancer. So the advice is not to decrease on that. So to continue those treatments without delay and give those patients priority in the slots at the daycare.
Thank you very much. Okay, let me check if there is any other question from the public. No. Oh, there's one here. Questions once, but just a moment. I have to refresh manually. There is a question that say, what can we do to better lung cancer patients with COVID-19?
What can we do to
better lung cancer patients with COVID-19? I understand to improve their evolution.
Well, I think I already mentioned it to you. So avoid the risks of infection by reducing as much as possible the number of hospital and outpatient clinic visits. So that's, I think, the most important issue. Perhaps also by avoiding those chemotherapy regimens which are more immunosuppressing. But okay, in lung cancer, there aren't that many different regimens. So you have platinum, pemetrexed, and etoposide. These are, I think, drugs which represent about 75 to 80% of the chemotherapy regimens that are used, and so they have a certain immune suppressive effect.
Perfect. Thank you very much. Okay, so we are on time. We are doing very well with timing. It is the time for the third presentation. The third presentation is presented by Professor Katerina Antoniou. She comes from the Department of Respiratory Medicine of the University of the General Hospital of Heraklion, Greece, and her talk is entitled Residual Fibrotic Lung Disease in Post-COVID Patients, Pure Imagination or Solid Reality. It's your turn, Katerina.
Yes, thank you so much for the kind invitation. It is a great pleasure to share this roundtable with you, and thanks also to the European Respiratory Society, as I'm head the secretary of the Assembly 12, so the ILD's Assembly. So I will have to answer if the post-COVID-19 fibrosis is imagination or solid reality. I think that it is a solid reality, but we have to further work on that. And what they did in lung cancer and in pediatrics, so the collaboration studies are very, very important. And we are doing also this through the ERS and other institutes. So as we are in Europe in a very critical point, where we are in the second vague, unfortunately. So the outline of the talk is the COVID-19 disease and the link with interstitial lung disease and pulmonary fibrosis following COVID-19 disease. So what we have until now is that the infection with SARS-CoV-2 may lead, of course, to COVID-19 disease, which is characterized by a severe viral pneumonia and ARDS in approximately 20% of patients admitted to the hospital, as you see in the slide. And you see also the factors that are associated with mortality in patients admitted to the hospital with COVID-19, apart from the age, the sex, female, we are a little bit protective, it seems, from our T cells, and other diseases could be the chronic cardiac disease, chronic pulmonary diseases, chronic kidney disease, and others such as malignancy. On the other side, the IPF tends to affect older people with a median age of 70-year-old. Men also are more often affected than women, and IPF is associated with different comorbidities such as diabetes, hypertension, ischemic heart disease, and acute exacerbation is highly mortality rate associated with surgical procedures and viral infections. Also, acute exacerbation is associated with the development of ARDS. So you see a very common profile of the patients with COVID-19 and IPF, which is the main ILD. Other considerations, specific issues for ILD patients is that chronic respiratory failure impacts COVID prognosis, may be more severe in patients with pulmonary fibrosis, particularly as we have already said with IPF, increasing age, past tobacco smoking history, which is associated with worse prognosis. And we don't know the effect still now of antifibrotics, while as also it happened with lung cancer, steroids, mainly prednisone on more than 10 to 15 milligrams and immunosuppressive maybe also impact the prognosis. Here is the risk stratification. As you see, that ILD patients, especially IPF, should be in a very high risk because of this comorbidities, age, severe disease, immunosuppressive therapy, increasing disease activity and triggering of acute exacerbations, as I have already stressed. However, it seems that a cumulative experience that patients with IPF, sarcoidosis, and other ILDs, it seems, at least for the first vague, that they didn't have a lot of severe COVID. Here is a pathogenetic slide from Professor Wells, says that virus trigger autoimmunity is well recognized, and you see the references. Viruses triggers ARDS, and this is well recognized. But what is unique about COVID is that both these pathways are so expressed and so frequently overlapped. So in pre-existing ILD, it may be very hard to distinguish between disease progression and the effects of COVID, as I will show to you. And COVID may trigger progressive ILD through autoimmune pathways. And here is the COVID-19 pneumonia and other ILDs. So this is challenging because you see that this is the provisional diagnosis of pulmonary edema. You see that the cardiovascular disease with chronic cardiac disease, it could be difficult to differentiate from ILD. However, post 5 days of diuretic therapy, we repeated RT-PCR, and it was a positive one with a final diagnosis of COVID-19 pneumonia. Here is another example with COPD this time, where COPD and COVID-19 mimic HRCT cystic pattern, and you see that after 5 weeks, the cyst enlargement but volume loss, so it was a barotrauma with fibrosis. Here is the example of COPD, and this is the example of IPF, where you see the IPF paradigm, you see IPF and COVID pneumonia. I don't think that it's very easy to differentiate. Here was an RT-PCR COVID-19 positive, and here you see the patient was, the final diagnosis was IPF plus COVID-19 pneumonia. And we don't know if it was an organizing phase or a rapidly progressive fibrosis. Difficult to say at that stage. Here you see UK from Gisli Jenkins and other collaborators. It is the outcome of hospitalized COVID-19 sessions, patients with ILD. It was an international multi-center study, and it seems that patients with ILD are in an increased risk, as you see. This is female and male. Increased risk of death, and particularly those with poor lung function test and obesity. Of course, these precautions should be taken to avoid COVID-19 in patients, of course, with ILD. And you see here is the blue, no ILD, and ILD, and the case fatality ratio. So obesity and poor lung function test. And here you see the survival rate in ILD when we are obese, and this is with FVC. And you see exactly what I've said, increased risk of death in IPF
particularly in obese patients and in patients with FVC less than 80%. Very clear results. And what is happening at the later phase disease? Here is a patient, a 58-year-old male with a history of fever and cough for 7 days and hypertension. And you see that after a positive test, after 2 weeks, and this is after 5 weeks, and this is a post-mortem autopsy, unfortunately, DAD in different stages, interstitial pneumonia, infarcts, we know the vasculopathy also in COVID, and bacterial superinfection. But what we know until now about the fibrotic phase disease, at present, the long-term pulmonary consequences of COVID-19 remains speculative. And here is a letter from Paolo Spagnolo in the Lancet, which is highlighting this peculiarity in these patients, and this is from our group. And we also think that we have a lot to do in this field, where the long-term follow-up of patients who recovered from MERS has not been reported, and there are a lot of commonalities between the patients of IPF and ILDs and maybe the pulmonary fibrosis afterwards. And we are very near to establish that in our population. However, this is again the Paolo Spagnolo's letter, and also from JAMA, that we need follow-up studies that we know until now that have shown that persistent radiographic abnormalities after ARDS are a little clinical significance and have become less common in the era of protected lung ventilation. However, about 40% of patients with COVID-19 develop ARDS, and 20% of ARDS cases are severe. As we've said, we need to do follow-up studies, and this is a case. I know the center is from Marc Humbert, where here is from Crélin-Bicêtre, France, who patients with COVID should be monitored because this patient had a rapid onset pulmonary fibrosis, the day 20, with extreme honeycombing abnormalities. And you see that he was a 30-year-old man with no previous medical history. He developed in day 20 this kind of fibrosis. And it was one of the first patients that they have started antifibrotic therapy. This is published to ERJ, but I know the follow-up of this patient with that Prof. Humbert shared with me. And this is also a first report on clinical and radiologic features of COVID-19 pneumonitis in a Caucasian population, highlighting that factors that are predicting factors for fibrotic evolution is the ground glass pattern that may be typical in CT of COVID pneumonia, and the evolution to pulmonary fibrosis is frequent in older morbidities and bone marrow involvement. And in this population, nearly 25% developed fibrosis. 15 were males, and the majority were male population, as we've already seen. Here is the early CT features with temporal lung changes in COVID-19 pneumonia in Wuhan, China. This is the 2 weeks, 3 weeks, and 4 weeks. And you see that they highlight the importance of long follow-up in order to determine whether the reticulation represents irreversible or not fibrosis. We can't predict it now. And this is also from Gisli Jenkins. He stressed that out in his presentation in ERS. And this is from Brazil, from my friend Leticia, who is now currently in France. that you see that the post-COVID radiology in inflammatory stage, 21 days, and fibrotic stage, 6 weeks. And here you see fibrotic changes only after 7 days of COVID-19. Also here you see diffusion capacity and lung volumes are differently affected in mild disease, pneumonia, and severe pneumonia. And here is from Ganesh Raghu and Kevin Wilson from ATS, a possible scheme about how to monitor patients with COVID pneumonia when they survive from severe COVID pneumonia. And you see that they stress the importance of very close follow-up with different modalities. And some, of course, in-person visits between 12, 24 months and 3 years. This is also from ERS, where they highlight that the primary objectives of this COVA-ILD study is the structured follow-up care program is essential to define the frequency and patterns of pulmonary abnormalities in moderate to critical COVID-19 patients after recovery. And you see that, of course, they suggest clinical examination, laboratory test, lung function, I think very, very important, thoracic CT, but we can't, of course, follow up the patient every 3 or 6 months with CT because of the consequences, and echocardiography. And you see the proposed schedule from this study. Of course, as Professor Wells is highlighting, the pulmonary functions should be triaged. Home spirometry may be crucial. Tighter selection of patients with a serial DLCO when we have severe disease. And maybe we have to do some more serial chest CTs and also some serial 6-minute walking test as a surrogate for serial DLCO in cases where it is not possible to have a plethysmography for the diffusion capacity and also for the KCO in order to evaluate both interstitial and vasculopathy. However, it seems here that we have different prognostic factors, respiratory symptoms, lung function, and CT findings in patients with post-COVID pneumonia. And you see a representative CT scan of COVID-19 patients with severe radiological findings. And the main patterns of follow-up were ground glass opacities and reticulation. And we suggest, such as other colleagues from Italy and from France, we also suggest, also from our analysis, that it seems that the lung ultrasound, as we can't, of course, perform a CT or a DLCO or let's say chest X-ray. I think what Athol says may be a good surrogate to chest CT, the lung echo. It could be something that we can easily do with, of course, less radiation. And it seems from the Italian study and from the French study that among COVID-19 patients, the lung ultrasound and the chest CT findings agree in the quantification of lung involvement and oxygen parameters. In the context of a COVID-19 pandemic, we suggest, and they also suggest these European sites, that the lung ultrasound could be an alternative. This is also some cases from Japan and from the other part of the world with fibrotic features and very rapidly progressing organized pneumonia. And what we have to do? Would we use antifibrotic treatment in those patients? Here is the paradigm of pirfenidone, and you see that pirfenidone is a and pleiotropic drug with anti-cytokines effects, anti-TNF-alpha, decreases the proliferation of fibroblasts, decreases inflammation, and we know the effect of fibrosis. And this is what Athol and Gisley and Peter Jost from the Brompton are suggesting the possible role of antifibrotic treatment in COVID-19 because you see that different pathways are activated in the same pathway also in COVID-19, ILD, pneumonia. And you see that different drugs apart from pirfenidone and nintedanib that they have already used and approved for IPF, other drugs could be also have a potential role in fibrotic stage, such as autotaxin inhibitors, GNK inhibitors, mTOR pathways, and others. Because you see that they inhibit the viral infection or disease, they could inhibit experimental lung injury, they could inhibit anti-IL-1 and IL effect, and possibly also, we know the tocilizumab, they could also have a role in anti-IL-6 pathway. And this is from Bruno Crestani from BISA, who is actually saying that we have to act in different stages and not only as antiviral, anticoagulant, immunomodulation, but also in fibrosis in these poor patients with antifibrotic treatment. And this is again the patient that from Saclay, from Mark Humbert's hospital, that I showed to you. And this patient only after 20 days developed this kind of fibrosis and entered in antifibrotic drugs off-label. And this is the study from Professor Sara Tomasetti from Florence, that they also, it is a multidisciplinary, multi-center study that they evaluate the risk factors, the prevalence and the characteristics of COVID-19 lung syndrome, and they do that in cryobiopsies and in order to identify and evaluate the characteristics of this ILD patients syndrome, let's say ILD syndrome, and to identify different risk factors. This is a study in Italy. This is a study in France, which has already started a few, I think, last month from the French government under here you see the PI is principal investigator is Professor Bruno Crestani, and you see that they have a placebo arm and nintedanib arm with the dose that we use in IPF. You see how they do the screening, actually 3 months after infection with HRCT. When we have more than 10% abnormalities and DLCO less than 70%, and we evaluate finalizing, yes, and they also follow the patients with spirometry, DLCO in different visits, 6-minute walking test, blood biomarkers, HRCT in 2 visits, dyspnea score, and of course the safety. In different visits. You see different other studies all over the world already started in COVID-19 disease, pulmonary fibrosis, with nintedanib and other drugs. Here it is the initiative of ERS, where we last June we talked about the management of this particular category of ILD patients, and here is the CRC recommendation and evaluation of these patients by Prof. Aliberti and Claudia Valenzuela. This could be a European respiratory network where we could share our data in COVID-19. And this is the initiative of PRS under the Professor James Chambers and Prof. Nicolas Ross. with different stages, and we will be involved in this, where I'm leading this group in guidance from follow-up, where we have to reevaluate and how to evaluate the COVID-19 patients after infection. Thank you so much.
Thank you for your talk, and congrats for it. And there was some questions. Unfortunately, we don't have time. I don't know if we have 15 seconds for a Christina question, and with that we have to close. So, Christina, if you want to use these 15 seconds, 20 seconds.
A short question. Is pulmonary rehab indicated for these patients, and when? During the acute phase or afterwards, after some weeks? I know that. Do you know if we
yes,
can start also pulmonary rehab, Professor?
I think the role of pulmonary rehabilitation is still to evaluate because we are now at the second vague. It is very difficult to establish the role of pulmonary rehab in these patients, but of course is something that we have to take in consideration the soonest possible.
Thank you. Okay.
Okay. Thank you to the three speakers. Congrats again for your great presentations. We have had a very nice hour in this morning, and thank you very much to my co-chair, Christina. It's very different to do this kind of meetings by this way, but I think we have had a great time, and we have learned, and we have shared very nice data. So thanks again.